we're always happy to talk space. So I'd like to begin with just a little bit of background of why we're here today. We've run this elective in the past, but it's mostly been on a local scale. This year, we decided to open this up to a national audience for really anybody who's interested for several reasons. About a year ago, we sent out a survey to all medical schools in the United States. We wanted to learn about whether interest in space medicine existed among medical students. As I'm sure you know, the general public has certainly generated a lot of interest in space over the past decade, but we wanted to see if this was also the case among the medical student community as well. So we sent out the survey and we had about 1,200 respondents from across the nation. They represent a diverse socio-demographic distribution reflective of the current medical student population. And we had some interesting results. Out of the 1,200 respondents, only about half had heard of space medicine at all. And out of everybody, only a third knew that space medicine was an official medical specialty. But the vast majority, around 87%, reported interest in learning more about space medicine if given the opportunity. So clearly, substantial interest in space medicine does exist among the medical student community. However, we also asked about opportunities for students to get involved in the field. Only 4% reported having access to a research opportunity at their institution. And only 8% had access to either an interest group or an elective like the one we're offering tonight. So clearly, while interest does exist, there's really not that many opportunities for people to get exposed to aerospace medicine. So we decided to run this elective in hopes of providing an avenue for students to get involved. We hope you find this helpful, and thank you again for joining. We're really excited about this.
All right, so before we get started, I want to go over a few things and address a few questions I've received over email. As far as the structure of these meetings goes, we hope to have an informal format to allow for discussion and interesting conversation. So tonight's meeting will be more brief, as this is the introductory session, but starting next week, meetings will start with Dr. Buckey giving a 20 to 30-minute talk about the day's topic based on chapters from his space physiology textbook. We'll then have a student presentation immediately after, which will be about a research paper related to the theme that day. And after that, we'll open up the floor to questions and discussion. Regarding the schedule, here's what we have right now. If there are any changes to the schedule, I'll send out an email and let you all know. We may possibly have guest speakers, but we'll announce those as we hash out the details. Regarding presentations, I will send out an email for signups and more information about that. But basically, we're looking for 5 to 10-minute presentations with PowerPoint slides about a research paper or a topic relating to the theme that Dr. Buckey discussed that day. This will be sign-up based, and again, I will send out an email with specifics, but it's not meant to be stressful, more of an opportunity for those that are interested to be involved, and we hope to get some good discussion out of it. Regarding recordings, so several people have emailed me about recordings because they can't make certain meetings. So we will be recording these meetings, and we'll work on finding a way to make them available to you. We just have to work out the specifics on that, and we'll get back to you. So I don't want to take up any more of your time with technical stuff. So with that, I would like to introduce Dr. Jay Buckey. Dr. Buckey is the director of the Space Medicine Innovations Lab here at Dartmouth Health and is also the section chief of the Hyperbaric Medicine Department. He earned both his bachelor's and medical degree from Cornell University in New York prior to coming to Dartmouth for his residency training. Dr. Buckey served as a flight surgeon with the U.S. Air Force Reserve for 8 years and was a payload specialist on NASA's Neuralab mission in 1998, during which he orbited the Earth 256 times, covered over 6 million miles, and spent nearly 400 hours in space. He has been an incredible mentor and teacher, and we're very lucky to have him. And with that, the floor is yours, Dr. Buckey.
Well, thank you. Thanks very much for that great introduction, and thanks for organizing this. This is a grace that we can do this. So I'm just going to give a sort of a short introduction to sort of the basics of gravitational physiology. And what I'm going to do, I'm going to get some PowerPoint slides cooking here. And so is that showing up on the screen okay?
No, not yet.
Oh, that's because I didn't share it yet. So okay.
So we're seeing the presenter view right now.
Yeah, oh, the presenter view? Okay.
Yeah, perfect.
Looks great.
Okay. All right. So sort of the basics of gravitational physiology, sort of what's different about being in space that you can't find here on Earth? Because it is a unique environment, and there are certain things about being weightless that are just different than what you can experience here on Earth, and as a result, give different physiological effects. So I'm going to start off, I know this probably isn't the best thing, but to start off with an equation. And basically what this equation is just force, where F is the hydrostatic force. So it's a force within a column of fluid, is proportional to the density of that fluid, the force of gravity, which is 1, as we're standing here, as I'm standing here right now, and the height of the column. So the taller the column, the greater the force at the bottom. And I'm going to show a little slide coming up that we'll just go through how to think about hydrostatic gradients, because they're important, because we have hydrostatic gradients throughout our bodies here on Earth. So this is a graphic from a book chapter by Gower and Thron. And what they did is it kind of explains a way to think about hydrostatic gradients. And excuse me, I just need to get something out of the way here. Okay. So this one on the left, it just shows you like a column of water in a beaker. So at the bottom, the pressure, let's say, is 0. But at the bottom, the pressure is proportional to the height of that column. So this is like if you had a graduated cylinder sitting on the table, there would be a pressure at the bottom due to the force produced by the liquid. Now you could do this the other way if you instead had this end open and that end closed, like if you put a straw in a cup of water, put your finger over the end and then lifted it out, the water stays in the straw. Well, there you would have a negative pressure at the top, and it would be 0 at the bottom, because that's where it encounters the atmosphere. So you would have a negative pressure at the top of this hydrostatic column, and it would be 0 at the bottom. So instead of doing that, what if you just closed both ends? So let's say you close this end and you close that end, and it's filled with fluid. So sort of in the middle is going to be where the 0 pressure is, and then the pressure goes down, or rather goes up as you from there down, and it goes down from there up. And this is starting to look more like the human body, right? So where this top part is our head, which might end up having a slightly negative pressure. And this is going to be our legs and feet. When we're standing, maybe have a higher pressure. Then they added something else to it. What if instead of these ends being rigid, they were flexible? And what you could see, if that was flexible and you stood the little column of water upright, there would be some little, sagging here at the top and some distension here at the bottom. And this is something that also has relevance to the human body, because if you go from lying down to standing up, and where you put a hydrostatic force from your head to your toe, and your legs are a little bit flexible, you'll see that your legs expand, that actually there's a little bit of expansion in your calves because of the blood that's moving down into the lower legs. So just going from lying down to standing up, you'll have fluid shift from the chest into the legs, and you could actually measure that, and you'll see that your legs get a little bit bigger. You could change the compliance of these different things. So like this one, you made this a little more rigid by putting 2 little elastic barriers in here, and this one just has 1 at the top. And then the other thing you could do to make it even more like the human body is you could add the pump to it. And so the pump is going to add on the pressures from the pump, just like, our heart adds a pressure, that happens every time the heart beats. But that pressure from the heart is then superimposed on these hydrostatic gradients that are in the system. So we always have these hydrostatic gradients in the system. When we're standing up, it's from our head to our feet. And when we're lying down, it's from the front of the body to the back of the body. Or if we're lying forward, with our chest down, it's from the back of the body to the front. So they're always present, at least here on Earth, these hydrostatic gradients. So why is that important? Well, this is a little graphic from Loring Rao's book about human circulation. And what it shows is that we have a great design, that we, by standing upright, we can, use our opposable thumb and look out over the grass, and be hunters. But it puts your head above your heart, which means it creates a challenge for your cardiovascular system all the time, because you need to be able to work against gravity to keep blood pumping to your head. And so these pressure little markers here show that because of the hydrostatic gradients, the pressures as you go from here down to there, from the top down to the bottom, get higher. And our best friend, the dog, doesn't have as much of a problem here. Most of their blood volume is at or above heart level. So we have that special problem of having to work against gravity all the time. And so for those of you who've saw the movie Top Gun recently, I'm sure you remember, I hope I'm not giving anything away here, but there was at least one of the pilots who passed out while they were pulling G's. And of course, that's because when you're pulling G forces, you're dramatically increasing the gravitational force that goes from the head to the foot. And that makes it even more challenging to keep blood flowing to your head. And if you don't keep up with the anti-G straining maneuvers, you can pass out. So just a little summary about these hydrostatic gradients that exist in our body, because that's going to be important when we think about what happens when you go into weightlessness. So when we go into weightlessness, you lose all those hydrostatic gradients. And so what's going to happen to the fluid distribution within the body? Well, on the left, we have somebody in 1 gravity, and on the right is that same person in 0 gravity. And what you can see is that there's the face is getting a little bit puffy. The legs are getting smaller because there's a loss of hydrostatic pressures in the legs. The negative hydrostatic pressures that used to exist in the head are gone. And so you have this fluid shift that occurs. But that's not the only thing that's going on, as we're going to talk about a little bit later. But this is, one way that people have often thought about what happens when you go into weightlessness. I just want to remind you, though, this also happens, maybe not to the same extent, when you just go from standing up to lying down. When you lie down, after being in the standing position, you're also going to shift fluid from the lower part of your body into the upper part of your body. And if you wanted to, you could measure the circumference of your calf, and you would see that when you lie down, the circumference of your calf is going to shrink. And if you look at the blood volume in your chest, you would see that would increase. And so a lot of this happens when you go from being upright to being supine, but maybe it's a little bit more exaggerated when you go into weightlessness. So, and here's a picture of someone, an astronaut. This is Dan Brandenstein, as a matter of fact. It's just a picture that shows this puffy face. And you can see here's a picture of his face before he went into space. And this is while he's in space. And you can see all the loss of you've lost a lot of the contours. There's a little bit of puffiness around the eyes. So that's that sort of puffy face look that people get when they're in space. So thinking about this, what do you think would happen to the pressure just outside the heart when you go into weightlessness? So we talked about the hydrostatic gradients. They're removed. There's a fluid shift. Fluid moves into the chest. What would we expect to happen to the pressure at the input of the heart because of all this fluid moving up into the chest? And I don't know what everybody's saying because I really can't see you all, but you might think that it would go up, right? That seems to make sense. When you go from standing upright to lying down, the pressure outside your heart, the central venous pressure, goes up. If you were to go from lying down to lying head down tilt, where you're, get even more of a hydrostatic gradient towards the head. Your central venous pressure, that pressure at the heart, right outside the heart, goes up. So it's not unreasonable to think that maybe what's going to happen when you go into weightlessness is that you're going to get a reduction, or rather an increase in your central venous pressure, the pressure just outside your heart when you go into space. So one of the projects I was involved in early in my career was a project to do just that, was to measure the central venous pressure, that's what CVP stands for, in astronauts going into space. And this shows the equipment that we used. We had a little transducer that was in the armpit at the level of the superior vena cava. So that's important because you want to make sure you don't have any hydrostatic gradients when you're making the measurements on the ground. And then we had a catheter that was inserted through a peripheral vein. So we had astronauts launch into space with this catheter in a peripheral vein. It's the same kind of catheter that they use nowadays for people who are getting long-term intravenous antibiotic therapy. So, and we looked, what we thought would happen is that we would measure this pressure and that it would increase. So here's a little summary of what we saw from, this is combined data from 2 space missions, Space Lab Life Sciences 1, which is SLS-1, and Space Lab Life Sciences 2, which is SLS-2. And we had 3 people where we measured central venous pressure, or CVP. So we have CVP on the y-axis here. This period here is when the astronauts are lying on their back in the shuttle awaiting launch. This 8 minutes is the launch of the space shuttle. And you can see here, you can actually see that's when the solid rocket boosters are firing. And you can see that increases pressure in the chest and CVP goes up. Then the solid rocket boosters fall away and you can see the pressure goes down. And then pressure builds up to about 3 times the force of gravity front to back. And you can see that causes central venous pressure to come down. But then what happens is that central venous pressure dropped. It dropped below the level that it had been on the ground just a few minutes before. So this idea that somehow we were going to send people into space, have more of a fluid shift perhaps than they get when they go from being upright to supine, and we were expecting that would cause the pressure to go up. In fact, it goes down. And if you look at some other analogs, this starts to make some sense, actually. If you look at, for example, body weight, if you plot pressure in the right atrium, which is very close to central venous pressure, versus weight, and I did that in a diagram here going from the highest weight to the lowest weight, there's also a relationship there that as the weight goes down, so does the central venous pressure or the right atrial pressure here. And so what may be happening is that maybe we don't have the whole story when we think about entering weightlessness as just being this fluid shift that occurs, that maybe there's other things going on. And what those other things might be is kind of described here. And this is a graph that Mimi Land had put together here from the Thayer School, which kind of shows a way to think about something else that is happening when you become weightless. So we talked about the hydrostatic columns that are in fluid, right? The hydrostatic gradients, but our tissues weigh something as well. And so what it shows here is that upright, you have the weight of tissues going that direction. When you lay down, you have the weight of tissues which are pressing on the outside of your veins and arteries. So you have a gravitational force that is pressing on the veins and arteries throughout your body. When you then go into weightlessness, so moving from one gravity here to weightlessness here, you're removing that force. And so what that does is it allows you to take the same volume, but hold it at a lower pressure. A a way of visualizing this is to imagine you had a fire hose and it was lying on the ground. If you looked at that fire hose, what shape would it take? Well, it would probably take sort of an oval shape, right? Because even though it had fluid inside it, it would also flatten out because of the, the weight of the hose and of it, sitting on the ground. So imagine if you made that fire hose weightless. Well, if you did that, that fire hose might just then assume a circular shape and contain that same volume in the hose at a lower pressure. So what may be happening is not just the fluid shift, and the loss of hydrostatic gradients, but also the loss of tissue weight and the forces that the weight of tissues produce. And so that is something you just can't replicate here on Earth. And it may be one reason why we see some unique physiology in weightlessness. And that unique physiology has to do with changes in the eye. And I don't know if you've read about this or know about this, but what has been happening is that astronauts have been coming back from long duration space flights with some changes in their vision, that they need different glasses because their vision's changed. And it happens over the first few weeks in flight. And when you look at the eye in some of these astronauts after they come back, what's happened is that the eye has become a little bit flattened. And that's which looks like there's a push on the back of the eye. And so one thought has been that that maybe this is due to increased pressures in the head. But from the discussion we just had, you're thinking, well, gee, where would those increased pressures come from? We just saw that if you go into space and you think the pressure is going to go up in the chest, no, that's not the case. It actually goes down compared to the supine value. So where would an elevated pressure come from that might cause the eye to be flattened? Now, some people think that it may be due to the fact that you don't have gravity helping to drain blood from the head. And maybe that's the case. But one thing we could think about is we could go back and look at hydrostatic gradients again. So, before we were looking at that graph from Gower and Thron, where we were looking at hydrostatic gradients, in the whole body, head to foot. But if we think about the head, and this is a graphic that Mimi Land had put together for an article that we wrote for the Journal of Applied Physiology. And if you think about what's happening in the head, there are hydrostatic gradients in the eye, and there are hydrostatic gradients in the head when you're lying supine. And when you go into microgravity, there'll be no hydrostatic gradients in the eye, and also the tissues of the eye will be weightless. And there's also no hydrostatic gradients in the head either. And the net result may be that even though the pressure in the head doesn't necessarily go up, it still can be the case that the pressure at the back of the eye can still go up because of the loss of those hydrostatic gradients compared to what they are in the supine position on Earth. So just a way to summarize that: hydrostatic gradients, loss of tissue weight, these are all very important things to be thinking about when you're thinking about what happens to the body in space, and also helps to explain why we see things happening in space that just don't seem to happen here on Earth, or at least happen in the same way. So that's one thing that happens when you're in weightlessness due to the lack of gravity. But there are other things that happen as well. And this is a graphic from the book Space Physiology. And what it shows on the right is somebody standing in 1G. And what we have in red here are what are called all the postural muscles. And what you can think of is those are the muscles that help to maintain our upright posture. So maintaining the upright posture is important, for us to exist here in 1G, but these muscles are not going to have a big role to play when you're weightless. And if you're wondering what a postural muscle is, you can just imagine if you went into a squatting position and stood up, all the muscles that are activated in going from that squatting position to standing up are kind of postural muscles, because they're all muscles that are designed to work against the effects of gravity. And so one of the things that you will see for people who go into weightlessness is that these postural muscles tend to reduce in size, because muscles need to be loaded in order to maintain their usual size and strength. And if they don't have that, then they start to atrophy. And just like if you had a cast at some point in your life, when you took the cast off, you could see that the muscles had shrunk dramatically because they were no longer, exercised, and so they start to lose mass. And that's what happens in space. If you look at muscles, particularly the postural muscles, you can see that they lose mass and they lose strength. And this is important because there's some indication that it might make astronauts more susceptible to back injuries when they come back if these spinal muscles are weaker. And certainly the soleus muscle is affected dramatically. You can see, on scans and so forth, that there's a loss of the mass of the soleus muscle when people are in weightlessness. So that's muscles. That's another area of gravitational physiology that we'll be talking about as we go through these lectures. And then this is an area that's dear to Semran's heart, I know. And this has to do with bones, because just as we unload those postural muscles, we also unload the bones. So bones, when they're in weightlessness, no longer have these gravitational forces and what are called ground reaction forces, meaning the force that we send through our skeleton every time we take a step when we're walking, or the forces we develop if we're doing weight training. Those forces are gone. And so as a result, bones start to lose mass, calcium comes out of bones, calcium goes into the bloodstream and then ends up in the urine. And the amount of calcium that ends up in the urine is not at all subtle. So this graph here on the left is data from the Skylab program, which flew back in the early 1970s, and more recent data from the International Space Station program. And the first thing that I want you to look at here is on the y-axis, we have urinary calcium. That's what UCA is. So that's the amount of the calcium in milligrams per day that appears in the urine. And this black line here is what is sort of a clinical definition of hypercalciuria, or too much calcium in the urine. So if you're above this level, you could be defined as being someone who has too much calcium in their urine, which might put you at a risk for forming kidney stones. But if you look here, and particularly a lot of these early data here is from the Skylab program, you can see it's not just a little bit above this level, it's a lot above this level, that there are people who are putting a dramatic amount of calcium into their urine when they're in space. And the little triangles are the space station, and then the other non-triangles, mainly just the dots, are from the Skylab program. And you can see that some people had really incredibly high urinary calcium levels due to the loss of bone from the skeleton. And just as we thought that weight might have an effect on the cardiovascular things we talked about, that it might affect central venous pressure and the cardiovascular effects we talked about earlier, it may be the case that weight is also a factor in how much calcium you put in your urine. On the right here is an analysis from Semran's paper. And what it shows is that although there are many factors that can affect how much calcium you put in your urine, weight is also one of them. So the more you weigh, the more likely you are to put more calcium in your urine, which kind of fits with the idea that you're having a greater unloading of your skeleton. Okay, so we talked about the cardiovascular system. We talked about muscles, talked about bones. The other key area is the balance system. And this is the effect of weightlessness you notice the most when you come back from being in space. So when you're in space, your body gets used to the idea that there's no sense of up and down that's coming from your balance system. And it adapts to that. You don't really notice that until you come back, and then you're back on Earth with a balance system that's been adapted to weightlessness. And when that happens, at least for me, I was walking around, I was a little unsteady. I was walking like somebody who was drunk, and I made very, very careful turns because I was using a balance system, basically, that, was used to the idea of not having a sense of up and down. This is a graphic that shows the inner ear apparatus. So within the inner ear, there's a particular area called the otolith, and the otoliths are little stones that are in a matrix and move these little hair cells in the macula. And so if you're upright, the little stones have some weight and they pull on the hair cells, and that is how you know that you're upright, as opposed to in 0G when these otoliths are unloaded. So this top one shows, the hair cells are bent because you're upright, and the otoliths are pushing on those hair cells. And then when you're weightless, you no longer get any information about up or down. So what's the functional consequence of this? And I'd like to show you a little video from Jacob Bloomberg, who's from NASA. And this will just show you a tandem walk test in astronauts after they've been in space. And so we'll go ahead and take you through this.
So what I want to do now is kind of give you a sense of what some of the changes do look like. So one of the tests that we have done in the past is called the tandem walk test. And this is a classical test of neurological function where a subject has to walk a straight line, eyes closed, arms over the chest. It's done in doctor's office, in neurologist's office all around the world. And we've been doing this test in a number of different experiments that we've been doing over the last few years. And so to give you a sense of what the postural instability that does occur, here we've got some video. So let me set this up for you. This is a post-flight test after a shuttle flight. So a shuttle flight about 14 to 16 days. And I'll show you the pre-flight. So this is the pre-flight version of a crew member. This is at Kennedy Space Center, tested just about 2 hours after landing. So this is the pre-flight version of it. And you can see our intrepid subject doing very well, as you might expect.
Are their eyes open?
They're closed when they do this, yep. And so here's the post-flight version of it. And now you can see increased instability, increased inability to, increased problems with maintaining a tandem walk. And you can see them moving off the straight line. So you can see quite an amount of instability post-flight. In fact, we have spotters on both sides to make sure that they maintain their stability. And so just to show you what it looks like on R+6, so that's 6 days after landing. And here you see a recovery here in terms of performance about 6 days after landing. And you can see it's not quite back to normal, but it's getting there in terms of recovery and of performance.
Great. So that's basically, I just wanted to give you sort of a quick overview of some of the unique effects of weightlessness, which are important for understanding what's going to happen to the body in space. So one thing we talked about, loss of hydrostatic gradient. So the pressures that ordinarily exist in a column of fluid are all going to be gone, and this will have an effect throughout the cardiovascular system, but it also has effects within tissues as well, which is the loss of forces due to body weight. So tissues no longer weigh anything. This is something that you just doesn't occur here on Earth, but there in space it happens instantaneously. And that effect may be one reason why we're seeing these lower venous pressures and why it's been so hard to try to figure out what's happening to the eye in space. Why are we getting those eye changes? Now, a lot of people will talk about the fluid shift that occurs in space, and that's true. You know, there is a fluid shift, particularly if you're considering going from being upright to being in space. You know, there's going to be this fluid shift. But I think probably for our purposes, maybe a better way to think about it is to imagine, instead of somebody starting upright and going into space, imagine somebody starting supine, lying down, and then becoming weightless rather. So if someone's lying down, you know, they've already had a little bit of a fluid shift, and now you're going to make that person weightless. So what happens then? And then it's not quite so obvious about what the changes are going to be. There may be some more of a fluid shift, but there are also going to be these other changes, the effects of tissue weight on blood vessels. So maybe that's a way that at least we like to think about how the body is going to adapt when it goes into weightlessness. We also talked about the fact that muscles and bones are unloaded, and that's going to lead to muscle atrophy and calcium loss from bones. We'll talk about this later, but that calcium loss, I didn't really get into this, but putting all that calcium into the urine, if you're not paying attention to that, it can increase the risk of kidney stone formation. And then there are no up and down inputs to the otolith. So the inner ear is not getting any information about up and down. You adapt to that very well in weightlessness. It's only a problem when you come back. And so it's these gravitational transitions that are going to be an issue as you adapt and then readapt to these different gravitational environments. So I was going to go ahead and stop there. We can open it up to questions.
Thank you.
All right, so yeah, normally we would follow up Dr. Buckey's discussion with student presentation, but we don't have a presentation today. So at this point, we can open up the floor to questions. I think we can try just people unmuting when they have a question, just be courteous and give each other a chance to speak.
And we'll send out a Google form starting next week for anybody who has questions. You can submit them ahead of time and we'll go in and moderate them. But if you have any questions right now, feel free to unmute. But if not, we'll send out an email either today or tomorrow with a sign up list for presentations that will start next week. Like we said earlier, they're pretty short, 5 to 10 minutes. We'll give some more details in the email as well, but anybody who's interested is more than welcome to sign up for a presentation.
Can you guys hear me okay?
Yes.
My name is Ryan Lasinski. I'm an MD PhD student at WVU, West Virginia University School of Medicine. A quick question is, are there any, particularly for the hypercalciuria that occurs, are there any like prophylactic medications given to people before they enter space, such as bisphosphonates, to prevent the breakdown of bone and obviously calcium release, or even in that regard, any prophylactic medications given for the changes in the cardiovascular system as well?
Yeah, so for the calcium issue, the main countermeasure has been the exercise program on the International Space Station. So every day, people do about 2 hours worth of exercise, which is over the years kind of focused more on resistive exercise rather than sort of repetitive cardiovascular exercise. So that seems to be a good countermeasure. I believe that some people have received bisphosphonates, but I don't know a lot about it. Some problems with some of the oral bisphosphonates is they can cause esophageal erosions. So one of the areas of interest for us is developing calcium measurement technology that you could use to identify those people who are having a lot of calciuria and focus the countermeasures on them. So that is one of our areas of interest. You can also prevent kidney stones by having to take potassium citrate, which alkalizes the urine and reduces the risk of stone formation, and that's been done. And then the other thing for stone formation is just to make sure that you don't let your urine get hyperconcentrated, because then that definitely does increase the risk. Cardiovascular, you were asking about, right? So, the adaptation that you get to weightlessness from a cardiovascular point of view, it's you could think about it as sort of like reestablishing the hemodynamics that you have when you're upright here on Earth, like the seated or standing hemodynamics. You do lose plasma volume, you lose some blood volume, but it's not, some people call it like spaceflight anemia, but it's really, you still have plenty of blood, and it seems to be an appropriate adaptation to weightlessness. The problem is when you come back. So when you come back and then these gravitational forces are reintroduced, you're going to be moving blood out of the chest into the legs, and there's going to be less blood. And so people are at risk for having orthostatic intolerance, or difficulty maintaining their blood pressure when they come back from being in space. So that's an issue.
Thank you. I appreciate it.
I think we have a couple more questions. Vienna, do you want to go next?
Yeah, sure. Hi, Dr. Buckley. Thanks so much for your presentation. I'm an intern from Australia, and I'm aspiring space doctor like most of us here.
Great.
My question was about the accuracy and the validity of bed rest studies. I participated in the AgBreezer study where we looked at the gluteal
good
muscles.
for you. Wow.
Yeah, it was fantastic. Well, not as a participant, but I analyzed some of the data. It was awesome. We looked at the gluteal muscles and how they change before and after bed rest. And there was a lot of debate around whether bed rest is actually good for as an analog for studying the effects of microgravity on the human body. So can you please comment on that, and if you think there's any other alternatives to microgravity analogs?
Well, I am so glad you asked that. And I could see Mimi smiling while you're asking this question, because we talk about this all the time. So the thing is that, bed rest studies have been around a long time, and how they really got started was in looking at the bone and muscle changes that occur. So when you do bed rest, people get muscle atrophy, they get bone loss, which do seem to mimic, the kind of thing that happens in weightlessness. What I'm concerned has happened over time is that people have tended to look at head down tilt bed rest as it's some sort of broad spectrum analog for space flight, that if it's good for one thing, it must be good for everything else. But the cardiovascular changes that occur in head down tilt bed rest are dramatically different from what happens when you go into weightlessness. So when you go from being supine to head down tilt, your central venous pressure goes up. When you go from being supine to weightless, your central venous pressure goes down. Your intracranial pressure when head down tilt goes up. In space, it most likely goes down. So the thing is that for a lot of these things, particularly the spaceflight associated neuroocular syndrome, I'm really concerned that head down tilt bed rest is taking us down a bad path, because I don't think it's a good analog really for those visual changes. It doesn't mean that it can't replicate some of the effects, but it's really dramatically different, which I hope I've demonstrated to these hydrostatic, analogies from what actually happens in space. But some things are good, so for some of these things like, being weight loss, dramatic weight loss, that is, in a sense, an analog for weightlessness. Also centrifugations, particularly GX centrifugation, is, kind of looking in things in the other direction. So if you look at what happens, for example, the central venous pressure, when you put somebody into GX centrifugation, it goes up. And of course, then if you extrapolate what would happen to it when you went to zero, it would go down. So, depending on the physiological system that you're looking at, bed rest may or may not be a good analog.
Thank you very much.
Sure.
Colton, do you want to go next?
Sure. Thank you, guys. I appreciate it. I'm an M1 from the University of Michigan. Thank you guys for doing this. I just had a question because we recently had a presentation from Dr. Jim Badgen, who was another astronaut.
Oh, yes. Uh-huh.
And he was awesome. And he was talking about the effects of PSI and how that kind of plays a role, like the air cabin pressure.
Okay. PSI is in pounds per square inch. Okay.
Yes, yeah, as far as like the air cabin pressure that they did different missions at, and they've tried a normal closer to Earth air pressure and then some that are much lower. And does that play a big role on the central venous pressure or the eye pressure? Or
Okay, so yeah, let's talk about that. So when you measure a pressure in medicine, like you measure a blood pressure, it'll be like 120 over 80. But what that means actually is it's 120 millimeters over the room pressure, or 80 millimeters of mercury over the room pressure. So in other words, it's what's called a gauge pressure. It's the difference, it's the physiological pressure referred to the room that you're in, right? And then so that's why you can measure blood pressure at sea level, or you can measure blood pressure in Denver, and it's still the same, right? Because it's referenced to the pressure around you. So for most cardiovascular measures like that, those pressures, since they're all gauge pressures and they're referenced to the pressure that you're in, they won't be affected by cabin pressure changes. They would be affected by cabin pressure changes if it's a sealed cavity, then it would. But if it's not a sealed cavity, then it wouldn't be. And you'll get the same blood pressure, central venous pressure, whatever pressure, as at the different atmospheric pressure as you would, at a higher atmospheric pressure or lower atmospheric pressure. Those pressures will stay the same as long as they're gauge pressures. However, the pressure change is important for the risk of decompression sickness, and we'll talk about that later on. But being at 1G in a 80% nitrogen atmosphere, our tissues are absolutely saturated with nitrogen. And so if you were to lower the pressure around us, that nitrogen wants to come out of the body. And if you lower the pressure too much or too fast, the nitrogen can come out of the body too fast and create bubbles, and that's what causes the bends. And that's an issue when you're going from the cabin pressure to a spacesuit, because a spacesuit is at a low atmospheric pressure, whereas the space station or the shuttle were usually at a fairly high, or not high, but they were at like a normal sea level atmospheric pressure. But we'll talk about that later on. I don't know if that was a good answer or not, but that.
Yeah, thank you. Appreciate it.
All right, up next is John B.
Hi, my name's John V. I'm an M4 at Stony Brook School of Medicine in Long Island, New York, and I am actually an applicant to anesthesiology, so I just submitted my application last week. So this is a broader question that I have about the field. I was just wondering generally, like, what, if any, intersection you've seen between anesthesiology and space medicine, because at least like from my experience, I've observed, there's lots of different positions used intraoperatively, like Trendelenburg, prone, supine, reverse Trendelenburg. And if those kind of concepts that are used in those intraoperative hemodynamic monitoring can be applied to, like space medicine as well. Is that something that you've noticed or have experience with?
It's very interesting you should mention that different positioning, because there have been cases of people losing vision when they've been positioned to do certain types of spinal surgery, which is thought to be due to increased pressures, in the head, affecting circulation to the eye, sort of the opposite, I guess, of what happens in weightlessness. So there is something to be learned by using those different positions and what happens with them here on Earth. As far as, anesthesia in support of surgery, I mean, a lot of people are very interested in doing, whether there's going to be surgery in space, and doing any kind of, extensive surgery in space is a ways off. But having good, simple, regional and conscious sedation techniques available would be really useful for some of these missions that are coming up. So, obviously you're not going to be doing, open procedures, but there is it is nice to be able to have that anesthesia available.
Great, thank you.
All right, sorry if I mispronounced your name, but Gufran, do you want to go next?
Sure, can you hear me?
Yes. Mm-hmm.
Hey, good friends out here. I'm actually an EM attending out in California, hopefully applying for space medicine fellowship for next year. So I had a question. So in terms of countermeasures for the effects of microgravity, I guess sort of for 100 years, people have proposed, artificial gravity through, spinning things, right? And my understanding is like back in the 60s, sort of a lot of the studies suggested that if, you would have to have a really kind of long radius centrifuge, which up until now hasn't been like any way to actually build anything that big in order to avoid things like Coriolis effects, sort of basically causing a lot of nausea and disorientation. But then some recent studies seem to suggest that you can basically adapt if you sort of slowly build up that perhaps you could slowly build up tolerance to short radius centrifuge. And I guess I was just curious kind of what you thought of those studies and whether you thought that was sort of a potential mitigation for some of the things.
Yeah, those are interesting studies. I think you're talking about Torrin Clark from the University of Colorado, I think, has been doing studies on that to see if you could do short arm centrifugation. So just to step back, so I guess everybody's seen 2001: A Space Odyssey. So, and you have the big rotating spaceship, which actually, if you look back, was the concept from Wernher von Braun from the 50s. So, but anyway, the idea is that, if you make the radius big enough, it doesn't have to spin that fast to create a 1g gravity. The problem is that if you can cause yourself to get dizzy and spin if you try to move around in that gravitational field. But anyway, so the desire has always been to, well, could you do centrifugation with a smaller radius? But then you have to spin faster. And then so you got to spin faster in order to get a reasonable amount of G. And then you get more problems with people having, getting motion sick or getting the Coriolis effects when they move their heads. And I think what people have been trying to do is to see if you can acclimate people to that, is what I believe Torrin is trying to do. And I think it's an interesting idea. Also, that's mainly GZ centrifugation, meaning head to foot, and which is great. But I think one thing we've also been looking at is GX centrifugation, because if we're right and the removal of hydrostatic gradients in the head from the supine position is contributing to the visual changes, well, then reinstituting those forces with GX centrifugation might be a reasonable countermeasure for those visual changes. So that's another countermeasure that isn't really thought about much, but why I like GX centrifugation, it's a heck of a lot more practical, because you can do it a lot more easily in the space available in most spacecraft.
Gotcha, thank you.
Sure.
All right, I think we have time for just a few more questions. Next on my list, Kyle.
Thanks for the great talk. I'm Kyle Anderson, MD PhD student from Rush University Medical Center in Chicago. I've done a lot of studying of bone, and I'm just curious in your thoughts. Bone and muscle unloading is more heavily affected in the lower limb, and you have vascular shifts kind of away from the limb. I would guess that most of the bone and muscle unloading is a result of lack of mechanical forces, as you brought up, but the vascular component is something to be considered as well. What's the potential role of the vascular supply shifting away from these tissues, causing atrophy or loss, do you think?
Yeah, that's a great question. So the question is like, does the blood flow or even the pressure, like the thing is that you're losing hydrostatic pressures within the bone as well. Is that a factor? And there is some, interesting evidence about that. The data, at least in the book, I have to update that book. But anyway, the graphic in there, what it shows is that in the data they took back in the MIR program is that bone mass actually increased in the head. And then if you think of what's happening, it's a lot of time in your head. Yeah, yes. Well, anyway, in the calcium chapter, there's a little graph. So anyway, so bone mass is increased in the head, which is very interesting, which may have to do with the fact that vascular pressures in the head are going to be on average higher in weightlessness than they were, either upright or standing on Earth, just because you've lost those hydrostatic gradients. Because, as that initial slide that I showed shows, a lot of times pressures in the head are negative. And this is a problem that neurosurgeons faced. If you have somebody seated up and you drill a hole in their head, they're going to suck air in. So because the pressure is negative in the head due to the hydrostatics, but in weightlessness, they're not going to be negative.
All right, so I think we have time for one more question, just out of respect for everybody's time. So Ben Johnson.
Okay, I'll have to make this a good one. Hi, Dr. Buckey. I'm Ben. I'm an MS4 from Johns Hopkins applying into emergency medicine. I wanted to ask you about the sand slide that you showed. If I have it right, there's a relative increase of pressure at the front of the eye and a relative decrease in pressure in the back of the eye in microgravity compared to supine. And I see how that explains the globe flattening, but I'm curious, that seems to kind of point away from a cause of the optic disc edema and the other effects like cotton wool spots seen in sands. And I'm curious if you have an explanation for that, or if you think there's something else at play, like the cul-de-sac effect in the optic nerve sheath.
Yeah, so I think, well, I guess the thinking is that because of that change where you're, in addition to losing the hydrostatic pressure, so that the pressure at the back of the eye is, and the pressure within the eye is lower and the pressure at the back of the eye is higher, you also lose the tissue weight. And so I believe that it's easier for the disc to become edematous. Do I have any proof of this? No. So, but it is a unique situation. You really can't replicate this on Earth. You can't create a situation on Earth where the aqueous humor is weightless, and what the effect of that might be physiologically, I'm really not sure. But I think we have to consider it, because it is the one thing that's totally different between weightlessness and what happens on the ground.
Thank you.
All right, so I think with that, thank you very much, Dr. Buckey, and thank you all for joining. We look forward to seeing you next week for a discussion on the effects of microgravity on the musculoskeletal system. And I'm just going to ask the Dartmouth students to please stay a little bit more, just so we can hash out a few details about the presentations, but the rest of you are free to go. Thank you again for joining.